Hi, everyone. Welcome to the session for IDSOG on hepatitis C treatment and pregnancy. My name is Meg Curtis. I'm one of the infectious disease fellows at the combined Brigham and Women's and MGH program. Right now I'm a second-year fellow, and I have the pleasure of discussing a paper with Dr. Catherine Chappell, and I will go ahead and let her introduce herself.
Yeah, hi, I'm Catherine Chappell. I'm an assistant professor in obstetrics and gynecology at the University of Pittsburgh. I am a member of IDSOG, a longtime member of IDSOG, and I did a reproductive infectious disease fellowship and a family planning fellowship. And now I have a real job. So I'm very excited to talk about really the most exciting and rewarding paper I've ever published in my life.
So the paper's title is Ledipasvir plus sofosbuvir in pregnant women with hepatitis C virus infection. And this was a phase 1 pharmacokinetic study. The aim of the study was really to compare the pharmacokinetic parameters of ledipasvir plus sofosbuvir between pregnant and non-pregnant women. And just to kind of run through the paper a little bit before we dig in further, the methods were 29 women were screened, 9 were enrolled, and they were all Hep C genotype 1, 4, 5, and 6. And the study comprised 3 12-hour intensive pharmacokinetic visits done at weeks 25 to 26, 29 to 30, and 33 to 34. And the primary outcome was really looking at the ledipasvir sofosbuvir area under the concentration time curve of the dosing interval, with secondary outcomes being SVR12, or basically negative viral load 12 weeks out, safety in the mother as evidenced by CVC and LFTs, as well as delivery outcomes and neonatal safety, including major malformations, body weight, length, head circumference, serial HCV viral load, and developmental outcomes. The results of this study showed no clinically significant pharmacokinetic differences between pregnant and non-pregnant women. There was a 100% cure rate, and there were no substantial safety concerns identified in the study. And these are just remarkable findings and represent really the first step towards developing a clinical pathway towards treating Hep C in pregnancy. And kind of thinking about this, I guess before we dive in, let's back up a little bit and talk a little bit about why it's even important to treat Hep C during pregnancy.
Yeah, thanks, Meg, for your excellent synopsis of our study. You know, what was surprising to our research team, but probably not surprising to folks that have used ledipasvir sofosbuvir, is that these new directly acting antivirals, they work really well. They have a greater than 95% cure rate outside of pregnancy, so it's not surprising that we had a 100% cure rate in our study. So with these excellent medications, in theory, hepatitis C eradication is possible. But the real problem is it's hard to get the medication to the people that need it. And who the people that need it right now are young people that have struggled with opioid addiction or substance use disorder. And a lot of times the young people do not come in for routine screening or screening at all for hepatitis C. And so they don't know that they have the infection, or if they do know they have the infection, they don't have access to healthcare. So, what we really have to do if we're serious about hepatitis C eradication is find these windows of opportunity for treatment. And I argue that pregnancy is a perfect time for that. Pregnancy is the time when women of childbearing potential in that reproductive age range, it's the time when they're most engaged in healthcare. I mean, if anyone's been pregnant, especially towards the end of pregnancy, you're coming in for weekly visits. I mean, when other time during your life do you come in that frequently to the doctor? And so this is an excellent time for us to really address the hepatitis C. And it might be a time when women are uniquely motivated to adhere to antiviral therapy like we see for HIV. And also using these directly acting antivirals in pregnancy, this might also prevent that around 5% risk of perinatal transmission. And therefore it might reduce the need to really worry about that whole issue of perinatal transmission, which we know that we're not routinely screening babies like we should. The other, I mean, ideally without using these medications during the actual pregnancy, we have to rely on treatment in the inter-pregnancy interval, which is very short for a lot of women, especially in the United States, between 1 to 2 years. And we have to take out the time because we don't have any data on breastfeeding. So it's not really enough time for women to get treated before the next pregnancy and before that other potential exposure to their next pregnancy. So I argue that, this is a really important thing for us to figure out how we can, if these medications are safe in pregnancy, and yet, as you mentioned, our study was the first step in creating that clinical pathway.
Also, sometimes women have increased access to drugs during their pregnancy that they might not in the inter-pregnancy interval. And so there's, as you said, so many reasons why this is such a unique window of opportunity to get treatment, both for maternal, possible fetal, and then also, larger public health implications. So what do you think in particular were the strengths of this article?
Well, I mean, I think that it was my study, so I'm very biased, but this really provides some proof of concept about hepatitis C treatment in pregnancy. And I will say, this was one of my first studies, and it was I didn't realize how difficult it would be. To identify women with hepatitis C that were willing to participate in a study of an investigational product in pregnancy. It was very challenging, and I really have to give credit to my research team, who have a lot of experience in clinical research. I could not have done it without them. And then also, we didn't have any loss to follow-up of any of the 9 participants we enrolled. We did have one participant that had a significant drug use relapse during the course of her treatment, but yet we still were able to retain her through the SVR visit and retain the infant through all 12 months of follow-up. So again, props to my research team. Yeah.
That must have been a very intensive effort and collaborative, I'm sure, with a lot of different people. And also to these brave women for, taking the step to be in this study. It's pretty awesome that you were able to find these people. I think that this was an incredibly strong study, and I really learned a lot reading it and reviewing it. But thinking about it, what are some of the weaknesses or things that you would have done differently?
Well, I mean, this is a small PK study. It's really more of a proof of concept. I mean, in that, it was such a difficult study to do. To enroll those 9 women, we had a recruitment period of 2 years. So it was very frustrating. With that, our sample size is small. And, it was a single site study. So with that, there's limited generalizability. And of course, it's amazing how long it takes to do these studies in pregnant women. We started planning this study back in 2015, when really latipizivir sofosbuvir was the only medication available for like ribavirin-free hepatitis C treatment. And so the issue with latipizivir is that it only has good coverage, like you mentioned, of genotype 1, 4, 5, and 6. So genotype 2 and 3 were left out. And so then valpatisivir sofosbuvir was approved in 2016, and we were like, oh, should we switch? Because that seems like because we found about a 10 out of our 29 patients that we screened had genotype 2 or 3 infection. And but if you've ever done a study in pregnancy, it would have required another submission to the FDA for a IND application, and it just would have really dragged things out many, many more years. So again, another weakness would be that we didn't use a pan-genotypic regimen.
Yes, but that also leaves room for future research.
True. Yes.
What data support that treating Hep C during pregnancy is safe?
Well, so first of all, with any time a new drug is brought to the FDA, they have to do preclinical studies that kind of indicate whether or not a medication might be safe in pregnancy. Now, to be approved, it's not required that that drugs be evaluated in pregnant women, but they do have to have this preclinical data. So, for example, for lidipasvir sofosbuvir, there was animal data that suggests that it was not at all, dangerous to administer in pregnancy. And the way they do these studies is basically they give this medication, a weight-adjusted dose to specifically rats and rabbits, and that would be higher than those that were given in humans, or pregnant rats and rabbits, and then look at the offspring. And the preclinical data actually didn't show any issues. And then lidipasvir sofosbuvir was actually FDA approved at a time when they were still doing pregnancy category evaluations, and it was actually given a pregnancy category B designation. So with all of that information, we put into our IND application, and then we submitted it, and then now we can add that to the data that we have in our 9 patients. And then the other thing that you can consider doing when you're thinking about medications in pregnancy is thinking about when would be the best time to give the medication based on the gestational age and based on fetal development. So it's thought that majority of the organogenesis ends at 16 weeks gestation. And so if you give medication past that time, if there's not anything else, then if you give it past that time, then in general, it's thought to be safer. So we started our treatment between 23 and 24 weeks, which is past organogenesis, but in the hopes of completing treatment by the time delivery occurred, to really maximize decreasing the risk of perinatal transmission, and also maximizing the ability for moms to complete treatment before they deliver. So yeah.
Kind of like a window within our window. Exactly. That's the perfect time. It was interesting too in the study, it showed that there was no HCV RNA in any of the umbilical cord samples, and that was probably because you were able to kind of get through treatment in that window before delivery.
Yeah, and honestly, if you look at our data, at our second PK visit, the viral loads came down really quickly. So even if you started DAAs later in pregnancy, it likely would prevent perinatal transmission, because it's thought that a majority of perinatal transmission occurs, like HIV, in that peripartum time. So during labor and delivery.
Another thing that I think that we may talk about a little bit is just thinking about, now that we have some momentum going for treating Hep C during pregnancy, There are a couple groups that have looked at cost effectiveness and kind of modeling Hep C treatment during pregnancy. And two groups in particular have shown that screening during pregnancy is cost effective. But right now, we really don't have any data on treatment during pregnancy in particular. We know that treating hepatitis C is immensely cost effective because of the downstream prevention of things like development of cirrhosis, hepatocellular carcinoma, but thinking more about women during this time and what makes that like a special population, I think is really something that's interesting to think about because in looking at the cascade of care, one observational study from here in the Boston area showed that only about 41% of women who had Hep C positive viremia during their antenatal visits even made it to their follow-up appointments. So if we could get women during this time when they're engaged, just like you said, Dr. Chappell, then this could be just a really amazing opportunity. And I think that there is a lot that could be done in terms of modeling these outcomes. And that's something that I have some interest in right now.
Yeah, I would really look to you to answer those questions. Because right now, I think as you mentioned, that all the cost effectiveness data is really like a lot of data in pregnancy is just extrapolated from the general population. So I look forward to reading your work about that. So I want to ask you, so how much data would you say is necessary to say that hepatitis C treatment is safe?
It's hard because we think of pregnant women as this special population that we have to really, in some ways, protect, but also that leads them to be excluded from therapies. And we see that right now with the COVID pandemic with the vaccine and therapeutics and whatnot. But I think we have to start with these pharmacokinetic studies in the beginning, and this was an incredibly reassuring finding. It was like, if you could imagine the best first step down the road, like that's what this paper was. And I think, next they're going to have to be like phase 2 and phase 3 trials to really show on a larger scale that it's safe. But looking at the outcomes that were chosen for this trial in terms of both maternal and fetal safety data, they were incredibly reassuring. And I'm really looking forward to seeing what the next kind of iterations of this and next trials that you undertake show, because I think it's based on what we've seen, these seem like incredibly safe medications.
Yeah. Yeah, no, I really like how you put that. So I think our next step, we just opened a study of the pan-genotypic regimen, valpatisvir/sofosbuvir, and we are planning a multi-center study of valpatisvir/sofosbuvir treatment in pregnant women, and this study will involve some IDSOG members that are very near and dear to our heart, including Dr. Jill Davies in Denver and Dr. Marcella Smid from Utah. So we'll look forward to that coming up. So I guess what we should end on is what would we see in the future? If we could see in the future, what would hepatitis C treatment of pregnant women look like?
Well, it seems like pregnant women, in my opinion, seem to have better outcomes when care is delivered in a more comprehensive, almost like medical home type setting. And so if we can deliver hepatitis C care to women in a place where they already feel comfortable with their OBGYN or their OBGYN's office who they've been seeing throughout their pregnancy, I think that would be the ideal way to provide this, or to have someone embedded, maybe an ID person, if that were available. But I mean, we've seen this in HIV care where when we cluster care, we have better health outcomes. And so that, I think, would be my dream for women with hepatitis C, and trying to just make sure that we address as many parts of their care as we can when we have them with us.
Yeah, no, I think you're exactly right. We need to create a one-stop shop. And for hepatitis C care in pregnancy, I like to think about it as another test and treat model. where when women come in for their pregnancy care, they're tested for hepatitis C and then treated for hepatitis C. And then the future will tell us whether or not, I think we have some data that is would be curative, likely curative treatment. And then it's still to be known whether or not that also would prevent perinatal transmission, but maybe in the future we could test and treat and really prevent perinatal transmission as well. So that would be my ideal pie in the sky plan for hepatitis C management in and around pregnancy. So.
Yeah, and how empowering to be able to show this mom, like, here, you're making this baby, but you also, are cured of this disease. It just would be a huge win, I think.
Yeah, no, I love it. Yeah.
All right. Well, Dr. Chappell, thank you so much for joining this Ask the Expert. As always, I've learned so much in chatting with you, and I'm just so excited about the possibility of expanding the care that we can provide to our pregnant women, and especially those who are most vulnerable, like people who come in with hepatitis C.
Oh, well, thank you. You've been so excellent, and I look forward to working with you in the future.